Hello, I'm Andrea Ramos, a nursing graduate student at UTA. I'll be presenting the impact of 30-day unplanned readmissions on the hospital budget, background, causes, and methods to reduce. As you know, many of our patients are covered under the Department of Health and Human Services Medicare Part A program. This plan establishes the reimbursement of costs associated with inpatient hospital care. In recent years, efforts have been made to simultaneously stabilize rising health costs and incentivize improvements in patient outcomes. Two key drivers toward this goal are: 1, the Center for Medicare and Medicaid Services, known as CMS, migration to bundled payments for treatment episodes, and 2, the Hospital Readmissions Reduction Program, an element of the Affordable Care Act that seeks to reduce patient readmissions after hospital discharges. Traditionally, Medicare was billed in a fee-for-service model. This meant all parties involved in a patient's hospital stay charged for every unit of treatment, service, and materials. As you see, the more that was done, the more that was billed. Today, the current practice is to focus on patient well-being, efficiency, and effectiveness of care. The theory is that if all parties were paid through a bundled reimbursement that did not respond to quantity of procedures, there will be a greater focus on providing patient-centered treatment. One of the key measures of quality of health care is the readmissions to an acute care hospital within 30 days of discharge from an inpatient treatment episode. The intent is the healthcare providers will strive to deliver effective treatment so that the patient will not need hospitalization soon after discharge. The impact of readmitting patients in a hospital setting has added $15 billion in taxpayer spending annually. Surprisingly, the rate of readmission is not uniform across the country, with variation between states and regions. Studies revealed that about 1 in 5 Medicare patients had to return to the hospital within 30 days of initial discharge. To address this, the CMS has increased the application of the HRRP's value-based scheme in place of fee-for-service across more procedures to incentivize robust patient treatment. A hospital's motivation to improve their rate of readmission is based on the HRRP's penalties. These penalties were based on a readmission scoring system that also accounted for the patient's age and health condition. The penalties were a 0 to 3% reduction in reimbursement, not only for the evaluated readmission conditions, but to all Medicare treatments. Thus, hospitals pay attention to their readmission numbers. A national survey of hospital executives revealed the most common reasons for readmissions. In their view, how the patient transitions from the acute care environment to their post-discharge recovery phase, what they termed as patient handoffs, was identified most frequently. Texas Health Resources is the dominant health system in the Dallas-Fort Worth region. Serving Hurst, Euless, Bedford, and surrounding suburbs, the HEB Hospital campus is an acute care facility located almost at the midpoint between Dallas and Fort Worth. Key personnel interviewed on the subject of 30-day readmissions were the Director of Transitional Health and one of the department's clinical nurse leaders. These are the numbers reported to CMS for THR-HEB in the third year of the HRRP mandate. This was the last year of evaluating just the original 3 conditions of HRRP. All 3 were within the expected national range. Notice that while heart attacks were the highest in absolute readmission count, heart failure was noticeably higher in terms of readmission percentage. The THR-HEB staff provided the last 6 months diagnosis-related group, DRG, readmission counts. These metrics are part of an overall collection effort that looks for trends and anomalies in patient outcomes. From this chart, you can see that most readmissions occur during the 2nd to 3rd week after patient discharge. The Director of Transitional Health and the CNL, as well as THR's reporting, revealed that heart failure leads in readmission percentage. This condition is not clinically trivial, and the discharge regimen must be taken seriously. Discussion with THR-HEB interviewees revealed that the challenges to be successful hospital discharge recovery can be sorted in 4 main categories. Observe that these are not mutually exclusive. Several can be present in an individual's patient care, and some can be difficult to discover if the patient is not forthright. In fact, it is often the rule with Medicare patients that multiple challenges are present. At the root of discharge process is coordination, information sharing, and follow-up engagements. In the near future, it is expected that more procedures will fall under HRRP's value-based reimbursement model. Proactive steps should include more case managers, more nurses, transitional care clinics, better electronic medical record functionality, and mobile health applications. Thus, hospitals will have to make investments in staff, facilities, and technology to meet quality measures and avoid reimbursement penalties. Questions or comments?